I'm Dr. Nitin Chaubal from Mumbai, India, and I'm going to moderate this session today. So I welcome you to this lunch symposium by Vinno, and I thank you all for joining us. There are still some chairs empty, so some of you can come forward and sit. So Vinno, as you know, stands for Vision in Innovation. And this is a very young company, but in the last few years, it has really revolutionized ultrasound imaging by introducing some new technologies. There are two platforms which are very attractive. One is what is known as the MOOS platform, which is for the conventional ultrasound. And the other one is what we are going to unveil today. It's a new imaging technology, which is the ultrasound resolution microscopy, or URM. And as the line for today's symposium is visualizing the invisible. And really, in the last few months, we have been working with this technology, and we have started seeing things which we never thought we will see. And that's really hats off to the innovation. So we have four excellent speakers today, and at the end of it, maybe we can take some questions as well. Our first speaker is Professor Liang Ping from the Department of Interventional Radiology, Chinese PLA General Hospital, Beijing, China. And she'll be talking on applications of ultra-resolution microscopy in tumor diagnosis and treatment. Over to you, Professor Pang.
Okay, thank you, Professor Ms. Chairman's introduction. I'm Dr. Liang Ping from Beijing, China. It's my great pleasure to have this opportunity to introduce our preliminary study on ultra-resolution microscopy in the diagnosis and treatment of tumors. It has well accepted the tumor angiogenesis is associated with the tumor genesis, tumor propagation, and progression. On this account, the dynamic vascular changes of tumor is very close to the pathological and the biological characteristic. Actually, the microvascular changes is the first sign, first signal of the tumor occurrence and progresses from the early to the progressive stage of the ture. It's an increase of the vessel quantity, density, and tortuosity. So it is play an important role in the tumor, the occurrence, and the progresses. Actually, at present, all the imaging modality, including micro-CT, ultra-high field MRI, OCT, all can detect the tumor diameter less than 100 μm. However, it's limited by the depth and the dynamic imaging. How to fill this technical gap? The ultra-resolution microscopy can resolve this problem, which can obtain both the spatial resolution and the depth imaging. The penetration depth can reach the very depth for the liver region and other organs. Actually, UIM experienced 5 steps. First, the contrast agent injection, the ultra frame rate acquisition, and the bubble signal isolation, and the moment of trajectory bubble tracking. Finally, the microvascular visualization. In China, the majority of the contrast agent use the Sonoview. Actually, the key technical support behind the URM is a Muse ultra-fast platform, which emits, compared to the conventional ultrasound emission, the Muse platform emits the massive plane wave, which obtain the ultra-fast frame rates, and then we can obtain we can realize the time to space conversion and obtain the high resolution images. And also from this platform, we can obtain more than 10 measurement parameters, including the vessel density, diameter, complexity, and the ratio of all patterns. And at the time limited, I want to introduce the clinical application of solid tumors in the following three aspects. First, for clarify the diagnosis. First is a URM in focal liver region. We enrolled 47 patients, including HCC in 30 patients, liver metastasis in 11 cases, FNH in 6 cases. We can see even at the depth of the 8.6 centimeter, we also can get the average smallest diameter 128 μm on URM. It's the resolution on URM is far superior to the CEUS and the CEPD. And the results reveal that there was significant difference among the HCC liver metastasis and the FNH, especially in the vessel density, fractal dimension, and the local flow direction entropy, which are critical parameters for distinguish the benign and the malignant tumor. And this is an example. We can see the HCC patient, the tumor is very vascular and also have a avascular area, and the blood flow direction very disorganized and chaotic. And also for the FNH using URM, we can see there's very typical features of the central myofold vascular shunting and the typical spoke view pattern, which corresponds to the pathological changes. And also for liver metastasis, it's predominant peripheral, very vascular at the peripheral area, and with a high vascular density and lower intervessel spacing. In the contrast, in the central, we can see the lower vascular density and the increased interspace vessel. And the second one, URM in thyroid nodule. Finally, we enrolled 420 thyroid nodule and set up a multimodality model. The results reveal that the URM combined the multimodality ultrasound can improve the diagnostic efficacy of benign and malignant thyroid nodules, which was better than other modality combination, ultrasound, combined the CEUS, and so on. In the subgroup analysis for difficulty differential diagnosis, like the TRICE 4ABC COBO model can reduce the misdiagnosis compared to the conventional ultrasound model. And those are examples. We can see both the hypoechoic lesion in the thyroid and both diagnoses the TRICE 4B. However, compared to the benign tumor, the malignant tumor have a low vascular area ratio and perfusion index, but all the malignant tumor have a characteristic of the higher complexity. And the third one is a URM in abnormal cervical lymph node. we enrolled the 260 nodules. And the result review, the multimodality AI model can significantly clarify benign lymph node, thyroid cancer metastasis, and other malignant lymph node. Those are examples. This female experienced the PTC after the operation resection, and also, although it had an enlargement of the lymph node, however, from URM, we can see the Helm-like distribution is corresponding to the benign lymph node. And in the center, the PTC and with the metastasis lymph node. Although we can see the Helm-like distribution, but it has the local perfusion defect. That is a typical sign of PTC, metastatic lymph node. And for others, lymph node, we can see the fireball-like appearance. The tumor is very vascular. The second part is accurate assessment of therapeutic response. This is an example. This female experienced the microwave ablation. From a conventional ultrasound, it revealed complete ablation. However, use the URM, we can see it's very tiny blood vessel at the periphery of ablation area. Let's review that the incomplete ablation at the peripheral tumor, so the further treatment is necessary. And another example, the patient experienced the microwave ablation, and the conventional ultrasound revealed that I think maybe some bubble after the thermal ablation is disturbed this observation. So it's unclear boundary. However, from the URM showed the very large size and a very clear boundary of ablation zone, which even envelope all the tumor with a safe margin. And also URM can monitor the dynamic tumor treatment response. This is an example. The patient with multiple HCC experienced 2 circles of targeted immunotherapy. Although the conventional ultrasound and the CEUS showed no significant reduction in tumor volume and size. However, use the URM, we can see the reduced the microvascular density perfusion. That's a positive response. That's very effective treatment. So for this patient, further continued treatment is necessary. And also we can predict and evaluate the tumor treatment response like the TACE or other local treatment therapies. Finally, it's a prediction of the molecular behaviors. In this study, we investigate the molecular biomarker of HIF1R, P53, and the METC, HCC. As a result, reveal the HIF1R overexpression, P53 mutation, and the METC positive, a close relationship to the angiogenesis, vascular structure, and then related to the HCC progression and so on. And on 4 different HIF expression, we can see there were a significant difference in the complexity and the minimal velocity, and also there was significant difference in the central complexity and the ratio of pre to central bubble density between the positive and the negative VETC growth. And also, maximum flow velocity is a predictor of progression in P53 mutation HCC. And this is an example we can see in P53 positive HCC. URM showed the high complexity and the velocity at the peripheral. However, in the P53 negative HCC with URM shows the high complexity and the low velocity at the center of the tumor. And for VETC positive and negative group, we can see there was significant difference between the central fractal dimension and the ratio of pre to central bubble density. Finally, we can see due to the technological breakthrough, Muse platform provides the ultra-resolution, ultra-fast frame rates, ultra-precise system, and the simultaneous workflow, both the CEUS and the URM. So it significantly improved the clinical innovation application, including the early diagnosis of tumor, accurate assessment of therapeutic response, and predicting the molecular behavior, and so on. I believe as the breakthrough and the innovation of medical ultrasound use the URM, it will have a bright future. Thank you.
Thank you, Professor Liang. And I think you correctly showed us how it improves the diagnostic accuracy in HCC, in thyroid nodules, and especially the cervical lymph node was very impressive. You could pick up that small area which was abnormal. And of course, you showed us the post-ablation applications and molecular. So very impressive. And I think this is an eye-opener for all of us, actually people who are now exposed to this technology recently. Thank you so much.
Thank you.
So we have our next speaker, a young person, Adrian Rogensberg. He's a senior consultant in pediatric gastroenterology and ultrasound. And he'll be talking on applications of ultrasound, localization, microscopy in clinics. Over to you, Adrian.
Thank you very much for the very kind introduction, Professor Chubal. Maybe you can dimmer the light a little bit. Thank you very much. So my conflicts of interest are here. And then I will start just going back to the 1950s when everyone was happy about seeing a black and white image and seeing from the outside to the inside, do this non-invasively. And then later on we got Doppler ultrasound, everyone uses it at the moment, and we got access to circulation and measurement of circulation. And then from the 2000s on we had contrast-enhanced ultrasound making perfusion visible. And now we are entering the era of ultrasound localization microscopy or ultra-resolution microscopy. And I really think that in like 5 or 10 years, everyone is looking back, like we now look back to ultrasound, Doppler ultrasound, or contrast-enhanced ultrasound. So, but I'm a pediatrician, and for us in Europe it's quite difficult because intravenous application of contrast agents are not approved, but we can do it off-label, and we do it a lot. And I think that children maybe are the best subjects to study on because the organs are very superficial and we have anatomical ideal situations like for imaging the brain with the open fontanelle. For example, I brought just a conventional transfontanellar choice of newborn, and there you can see really the whole brain and the perfusion doing or applying the contrast. And we did a prospective study on neonates with a transposition of the great arteries, and they all undergo heart surgery on the lung heart bypass. And we performed choice of the brain in these neonates, And during the very critical step of this operation, where you have a very low flow of the lung and heart machine and cooling of the patient, you see really a perfusion deficit of the brain, and this could lead to the later on clinical outcome of these babies. And from this point, we went further and we discovered ultrasound localization microscopy. And in the next study I will show, we applied this again in newborns with an arteriovenous malformation, vena gallini malformation of the brain, undergoing endovascular treatment. And you need a very long sequence, about 1 minute and about 1,000 frames, to apply ultrasound localization microscopy with open available codes at the moment. But at least you can track every individual bubble, follow the bubbles, and then, as we heard before, you increase the resolution and you get a super resolution of the microvasculature. And here you really depict the cortical arteries, the capillaries, and also the connections to the outer brain. And in these newborns, after the treatment, we really saw by ultrasound localization microscopy that vessels are reopening and the circulatory is changing again. And in the next step, we can then calculate different parameters, as we heard before as well, like density of these bubbles, velocity, the tortuosity, directivity, or the distance. Next, I will show you a case where we applied ultrasound localization microscopy in perinatal stroke. And with conventional technologies like CT, MRI, ultrasound, you maybe have a glance that there is something wrong on the left hemisphere, but you need at least different diffusion-weighted MRI sequences or choice. And then you really see on the first moment there is a stroke of the medial cerebral artery of the left hemisphere in this neonate. And this is good, and this is nice, but what can we do now? We track the bubbles, and then on the first side, we see a hyperperfusion of the left hemisphere, which is typical for these cases. And if we then depict the stroke region in detail, we can not only depict the stroke by time, but we can also see the occlusion of the vessel of the medial cerebral artery and the residual perfusion. And I think this really opens a huge, or is a huge opportunity for these newborns, because traveling with these babies from the ward to an MRI machine takes you half a day and is really stressful, but you can do really bedside, right away diagnostics with ULM and contrast-enhanced ultrasound. At the moment, we're conducting a next study in neonates with asphyxia. It's a critical situation during perinatal period where they have less oxygen and struggle with very high mortality later on. And by performing ULM, we saw very specific perfusion patterns correlating with the outcome in the MRI. So again, we think that ULM to some extent could replace or even give additional or faster information than the MRI in these babies. And in this study, we not only imaged the brain of these neonates, we also imaged the kidney. And I think in children it's a special problem, but also in adults, that we have motion in some organs. So what we can do, we can correct the motion by also public available motion correction codes. And if we correct the motion, we can then apply ULM again and get density, velocity, and directivity maps of neonatal kidney. But we didn't stop at this point, because now we have so much data and so much information, so we can also dig therein. And what we know from preclinical models is that we can not only follow the bubble, but we can also analyze the way the bubble is traveling. Like in the glomerulum of the kidney, the bubble is first traveling very slow and then does circular movements and then travels back. And of course, this way we tried in these neonates as well. And yes, we can depict glomeruli in neonates by this method. And unfortunately, in these cases, we didn't have a biopsy because there was no reason for it, so we cannot correlate it with a histopathology in these cases. But again, going back to this, we are quite sure that we depict glomeruli, because if a bubble is traveling along a distance, we can calculate this by a distance metric method, and then show you really the individual glomerulus in the cortex of the kidney. And to prove our point, we did a study in kidney transplant patients, adult kidney transplant patients, and in these 10 patients you see a wide range of glomeruli count. And in these patients we also did histopathology, and we saw a correlation between our glom count, as we named it, and the histopathology. So I think we are really close at doing an imaging biopsy here. But we are here at Vinno because it's always getting better. And with innovations, you can do it faster, better, and more applicable for clinicians. And as we had before, with this technology, we don't use the conventional focus beams, but plane wave imaging, so we get a much higher resolution. So in terms, before I said we need about 1 minute of a stable video sequence to get about 1,000 images which we need for the analysis. If we have a high frame rate device with between 300 and 600 frames per second, we need less than 10 seconds, maybe 3 or 4 seconds to get the same results. And for an algorithm, it's even easier to follow a bubble because it's traveling very smooth. It's like if you watch a video from the early 80s, it's really not smooth. Yeah, but if you watch it with a very high frame rate, you get a smooth image, and the same with the ultrasound technology. So these are the same transplant patients I showed you before. We also imaged it with a Vinno Ultimus 9, and you can actually see the bubbles also in the very early phase of contrast arrival, and then you can do the same with a linear probe to get even a higher resolution of the cortex of the kidney. And then you have your measurements, or before that, if you go into anatomical details, you really see that the resolution is up to the smallest capillaries which you can find in the cortex of the kidney. And then after visualization, you can also measure like the density of the bubbles of the whole organ or in the kidney cortex. You can look at the velocity of the microbubbles, also again the whole organ or the kidney cortex, and the directivity. And all of these parameters are useful for us clinicians. There are several other parameters which can be calculated, for example in AngelMap, which could be interesting in tumor, as we saw it before. And you can also go for the vessel diameter, see the change of the vessel diameter in different diseases, or even the vessel curvature can be calculated. But I showed you something which I think is the most promising, or one of the most promising things in kidney diseases, is the imaging biopsy. And this can be done by Vinno as well. But before that, I will show you a patient with a kidney infarction, which you couldn't really depict in B mode or contrast sequence, but with a URAM, you really depict the infarction of the kidney in this area. Again, with the parameters like I showed you before. So now I come back to the imaging biopsy, and with the new software release of the Vinno company, you can now also do a glomerular count inbuilt in the system. And what took us about half a year and to get an imaging biopsy is now just one button at the software of the new machine. And we're really psyched about this and explore this further in our latest studies. So next I will end with a video sequence of a brain from a rat, which is known to a lot of you, but I think we're very close to have similar images in neonates as well. And with this I will close the talk, and I see also a very bright future for URM because we have a new way for less or nearly non-invasive imaging in sorts of patients from childs to adults, from healthy to deceased people, and I'm looking forward to taking your question afterwards.
Very, very impressive. I'm sure there will be a lot of questions, but I mean, your images on brain and kidneys are really fascinating. We'll ask you questions at the end of it, sure. Thank you so much. So our next speaker is Rajas. He's again from my town, Mumbai, India. And he's a young budding radiologist, always looking out for newer technologies. And in the last 6 months or so, he has got a new tool in the form of URM. And he's going to talk on various applications which he has been doing. Over to you, Rajas.
Okay, good afternoon everyone, and it's fantastic being here at JSON and the WFUMB. Okay, so what we have is this basically new toy to play with, right? And we call this URM. So we've been trying to use it in different clinical applications and seeing where this really helps us from a clinical perspective. So it's really fascinating, like Dr. Adrian showed, the evolution of contrast. This started when we started seeing these contrast images somewhere around 2008, 2009, when I just passed out of medical college. It was really exciting to see this. And in no time, we had these maps which were giving us more data. So getting rid of the subjective analysis, giving us more objective analysis. And in the last few years, we started seeing these newer maps coming up, with the time of arrival, the wash-in curve, washout curve, very, very exciting. And now within no time, we have this fantastic technology, which is URM, which, like Dr. Liam mentioned, what we are doing is tracking the individual microbubbles as they are passing through the field of view. And we'll see how this helps us in our clinical practice. So to put it in a nutshell, color flow of power Doppler is when we are evaluating it at about 200 to 500 microns. When we turn on our microvascular imaging, we are looking at about, say, 100 to 200 microns. But with ultra resolution microscopy, we are going right down to 50 microns. And this is the difference it makes in clinical practice, right? So even with a super microflow resolution, you still are, wondering what is the presence of vascularity in this peripheral area. But the moment you do your contrast and turn on your URM, you're very, very certain how well the flow is going all the way to the cortex. And again, Dr. Adrian showed us some fantastic images on this. So I'm not going to go over the features of this again. Dr. Liang has already explained. So we have a hemodynamic map to explain how the bubbles are tracking. We have a density map. We have some quantitative perfusion indices. Again, very useful. And the machine gives up this whole range of parameters in terms of the vessel ratio, the complexity level, the density of the vessels, the blood volume, the perfusion, a whole lot of which we can probably experiment and work on in the future. So let's see how we apply this clinically. Now, for a long time, of course, looking at carotid stenosis has been the realm of color Doppler, right? And we've been grading our stenosis with color Doppler. But now we've started using the ultra fast CUS, which is available. And where this helps us is in situations like this. Here, for example, on the color Doppler, you can see that this is looking like a total occlusion, no flow going through at all. But when you do your ultra-fast CUS and you add your time average parametric maps, do you the URM, you can see that this blood is actually trickling down and there is some flow which is going distally. So you're still in a pre-stenotic stage rather than stenosis, and this is again going to be very important for the clinician to know. Right, you do have angular maps, so you can look at the direction of the flow as well. But again, it is the density maps, the time average maps, the average parametric maps, which really help you in this kind of a situation. But a big challenge that we've always had is looking at ulcerated plaques, right? And on Doppler, this can be very, very challenging. So we have done contrast for these, and you can see how beautifully you can see this on the urodynamic map. The moment you see this ulcer crater, you do not have any doubt in your mind that this is definitely an ulcerated plaque, and you know that this is going to be a little bit of a tricky situation. And the same occlusion patterns we can apply in peripheral vessels as well. So this, for example, is the popliteal artery, and you can see that there's complete occlusion over here. But Just knowing the presence of occlusion is not enough. What we need to see or what we need to identify is actually the presence of collateral channels, which can be again challenging on contrast, on Doppler ultrasound. But using our URM, you can see how beautifully we can see these collateral channels crossing across, and this especially assumes a lot of importance when we look at calf vessels, because the management is going to be dependent on the presence of these collateral channels. Hopefully in the near future, we may be able to measure how much is the flow going through the collateral channels as well, and again, that will be a very, very important clinical aspect. Coming to the liver, Dr. Liam has already showed us some wonderful cases. So all this while, we have been relying particularly on the late phase to diagnose the HCCs, where we look at a mild and a late washout, but now we have more information coming in the arterial phase as well. So if you look at all these parameters, and we have narrowed down on a couple of parameters which we thought were useful, we could see that there's increase in the blood volume as compared to the normal liver, there's increase in the complexity and the curvature of the vessels, and these parameters could potentially help you to identify lesions at a very early stage. So when you have these CUS, LIRADS 3 and 4 lesions where it is a little challenging to know what the lesion is, this is something where URM can really be quite helpful. Again, Dr. Liam did show us the post-treatment HCC, again very useful, because even with contrast, sometimes you do have a challenge looking at the perfusion of the lesion or in the periphery, and once you do this URM at a single touch of a button, you have so much information coming in. You know for sure whether there is any peripheral perfusion or no. You know whether this patient needs to re-undergo the procedure or the patient has been treated well. Urology is a fantastic application of contrast ultrasound. We've been using it for quite some time, but let's see how URM helps. So this, for example, was a complex lesion in the kidney. We were not quite sure what it was. We did the contrast, we did a peak intensity map. We were still a little uncertain as to what it is. But the moment we did our URM study, what we are seeing is that the bubbles are only in the periphery. There's no bubble which is passing through the center. And we were quite sure that, okay, this is going to be a renal abscess. Again, if you look at the quantitative perfusion map, no flow in the center at all, and this indeed turned out to be a renal abscess. The patient went with antibiotics, he came for a follow-up in some time, and the lesion had completely disappeared. So this is how URM can really add on to the confidence in your diagnosis. Again, coming to evaluation of cystic lesions in the kidney, right? When you do have septae, some of these septae can be quite thin, and even when you do a contrast, to realize the transient enhancement within the septae can be quite challenging. But here, for example, we have a cyst with septations, and when we see the URM study on the hemodynamic map as well as the density map, we see that there's no bubble tracking across the septae, so we are very, very certain that this is going to be a simple cyst, so you're not going to be worried about this. And Dr. Adrian did show us this recent function which is added onto the URM ultraglow function. And what this helps us to assess is the density of the functioning glomeruli, right? And you know that the moment there is a reduction in the number of the functioning glomeruli, or the density of the functioning glomeruli goes down, you are going to be looking maybe at a medical renal disease, maybe at an ATN, maybe at a rejection, and all these things are a huge scope in the future. Now, when it comes to urinary bladder neoplasms, what we need to and what we try to always identify is the enhancement within the lesion, and we want to compare it with the adjacent bladder mucosa. Again, looking at the routine contrast, this can be quite challenging, but once we get our maps on the URM, for example, this perfusion map, we are very, very certain that there is enhancement within the lesion. There's definitely increase in enhancement as compared to the residual bladder mucosa, and you know that, okay, this is definitely going to be a neoplasm, and this in fact turned out to be a transitional cell carcinoma. And I was just discussing this with Dr. Adrian some time back. One of the challenges which we see in pediatric populations is the testicular torsion. And when you have a patient with a testicular torsion, you have a baby who's crying, it's very difficult to scan. Doing a Doppler, you're not really certain as to whether there's flow within the testes or no. And then what you do is go ahead and give a contrast. But the moment you add URM maps onto this, you are able to see each and every individual bubble if it is tracking through the testicular parenchyma. And in a situation like this, where you know that, okay, there's no flow within the parenchyma at all, you are very, very certain about your diagnosis again, right? So this adds a whole new dimension to your confidence level. And similar to what we saw with the renal cysts with septations, here we do have ovarian cysts as well. Again, this of course was a relatively easier one to see because the septae are quite thick, they are enhancing well. But again, at times you may have very thin septae, the enhancement may not be as easily seen. And this is where again your urodynamic maps and your perfusion maps can be of huge help. And yes, coming to lymph nodes, again, we have been experimenting with the lymph nodes as well. And when we want to identify the lymph nodes, whether they're normal, abnormal, all this while we have been relying on Doppler, but we have started doing contrasts for these cases. And we can see how well we can look at the pattern of the flow. We can see how well the lymph node is perfused, whether it's a central, whether it's a peripheral perfusion pattern. And looking at them, we are going to be more aware and more certain that this is going to be an abnormal lymph node. But one of the challenges which definitely comes up when we do these contrast studies is trying to identify what the problem is. And typically in a setting like ours, where we see a lot of tuberculosis patients, trying to identify the infective ones from the malignant ones is definitely a big challenge. This, of course, was a tubercular lymphadenitis. You can see peripheral flow, and this was only proven with biopsy. But we did compare, some of these parameters of the URM with the infective as well as malignant lesions. For example, this was a non-Hodgkin's lymphoma, and we saw that there was a certain definite increase in the vessel ratio, the complexity levels, the increase in blood volumes, all happening more in cases of a malignancy as compared to an infective lymph node. So again, a very useful tool when you want to differentiate between an infective and a malignant lymph node. As far as thyroid is concerned, we have avoided doing a contrast for a long time. Why? Because we were not understanding the kind of patterns. We could see the enhancement pattern in a benign node. We could see the enhancement happening within the malignant node, a nodule as well. So benign as well as malignant nodules were showing enhancement. So the problem here was differentiating. So what we saw when we did the URM, and which was again very difficult to see with the contrast study, was the complexity of the level. Now again, going back to Dr. Liang's lecture when she spoke about the complexity of the vessels, you look at the density of the vessels, there's relative peripheral central sparing of the vessels over here. Here the vessels in the center are much more complex. This itself gives you a clue that, okay, this may potentially be a malignant lesion, right? And again, we did this over multiple lesions and we kind of saw the same pattern. We could see that the benign lesions had a peripheral sparing of vascularity, whereas in the malignant lesions, you had more closely packed vessels, there was higher density of the vessels, and you could see this more central, increased flow in the center with a lot of curving of the vessels as well. So again, this is something, this was not seen on the routine contrast, but we have been able to see this with the URM. And another thing which we can do with the URM is look at the parameters within the lesion, and we can look at these parameters in the periphery of the lesion as well. So again, this is something that can be used in thyroid or even breast to predict the presence of malignancies. A very interesting thing that we have actually done is looking at the synovium. Now, mind you, we have been seeing a lot of inflammatory arthritis over a period of time, and all this while, the grading system is we follow the Euler-Omrack grading system, where we look at the thickening of the synovium, we look at the vascularity within the synovium, and the routine contrast, though it does show the presence of enhancement, it's kind of very difficult to quantify or label and to say as to how this is. But now, using the URM techniques, we not only see this flow much better, but we are able to quantify them. We are able to look at the vessel ratios, the complexity vessels, the perfusion parameters. We can look at the perfusion indices. And this can potentially be used when these patients come back for a follow-up to you after they have been on the disease-modifying drugs to see how well these patients are progressing. So again, a very useful thing in the future. Now coming to the breast, we do have limited experience with breast, I'm not going to deny that, but this is something which I want to show. Now with the linear probe, and this is a challenge which we've always been having with the linear probe, is that the images are not really high quality. You see very little contrast trickling in, and you're not very certain of a diagnosis, especially in a relatively avascular lesion like in a breast lesion. But now using these urodynamic maps, what we are able to see is this flow within the area. And what was a big challenge identifying it over here, we are now able to see the vascularity over here. This was an invasive ductal carcinoma, and this can actually help us to guide the biopsy. So once we know that, okay, this is the area which is more vascular, you can direct your biopsy needle over here and get it from this particular lesion. So thank you so much, and I would like to appreciate the help from the Vinno team, especially Mr. Arul and Mr. Balasubramanian over here for helping me with getting these wonderful images. And greetings from Mumbai, and I would like to say that the WFUMB 2029 has been declared in Mumbai, so I would love to see all of you over there. Thank you very much.
Thank you, Alex. Very impressive. You almost covered everything from head to toe, and really impressive. I'm sure there will be a lot of questions for you. So we come to the last speaker of the session, Dr. Dong. She's from Vision Hospital, Shanghai Jiao Tong University, if I'm pronouncing it right. But I had an opportunity to come to this university some time back, and she's going to talk on the future of microvascular assessment with super resolution ultrasound in small parts. Over to you, Dr. Dong. And she's going to speak on behalf of her team, and all the team members are there.
Thank you for the chef's introduction. It's my pleasure to represent our team and deliver the reports of our clinical work we have done. Because we have already used the Vinno devices for almost 2 years. So today my topic is the future of microvascular assessments with super resolution ultrasound in small parts. Yeah. As we all know, the super resolution ultrasound system presents us with amazing images of blood vessels and tumor microvasculature. Since the SRUS breaks through the limitation of conventional ultrasonics. We all know the principle of URM or SRUS because it can locating, tracking, and accumulating microbubble trajectories. However, this is still only at the level of imaging the blood circulation. So we are always thinking about how to expand the clinical application based on this technology. We know that since the body fluids are circulating flows, vascular system including blood vessels and lymphatic vessels, and they communicate and exchange substances in the institution space through the capillary network and the capillary lymphatic network. So the lymph node metastasis or distant metastasis of tumor is also based on this interaction between blood and the lymph. Thus, let us to consider if we can alter the injection routes of the contrast agents. We may have innovation of something new. We can inject the contrast agents through 3 routes. One is the conventional intravascular, intravenous. Another one is the intralymphatic. And the third one is the interstitial. So firstly, our work of SRUS in breast lesions. For traditional intravascular, we can showing the microvascular in differentiating benign and malignancies. These are all breast cancers, but for the left one, this is a triple negative breast invasive ductal carcinoma, and the right one is a non-triple negative ones. We have not only beautiful images, but also precise quantitative parameters that's available for us to analysis. So we have done our study that we have 934 cases of breast lesions, and combining intravenous SRUS, which show the microvascular and contrast-enhanced ultrasound and conventional ultrasound for predicting benign and malignancy. And we can see the model can achieve an area on the curve of 0.948. Because we all know for breast ultrasound, it already have very high performance of diagnostic values. So even if a little improvements will be better. So next part, we do the intravenous contrast-enhanced ultrasound with microvascular SRUS in predicting the molecular subtype of breast carcinoma, such as HER2 positive and HER2 negative. And also we can use this in the proliferation of breast carcinoma in different groups, like the Ki67 higher expression group and the lower expression group. In this way, we use a Luncheon regression model to selecting the valuable features, and also use SRUS combined with contrast-enhanced ultrasound for predicting different molecular subtype. And the proliferations, we can have a little bit better performance than conventional ultrasound and contrast-enhanced ultrasound. And the second part is the SURS in the sentinel lymph node of breast cancers. As we all know, the sentinel lymph node is the first lymph node that receives drainage from the primary tumor. Pre-operative assessment of the sentinel lymph node is an important basis for the formulation of the surgical plan. We know that by intravenous routes, we can have the blood flow of the lesions, but by lymphatic route, we can get lymphatic flow and combine them together. We can have more information than conventional one. So we can see this is an intravenous route. We can show the microvascular vascular in the lymph nodes of metastasis. And this is another way. We're using the microlymphatic way to show the using SRUS, and we can see the perfusion defects. This can make us to show have a higher confidence of diagnostic, because this is this is a metastatic lymph nodes of breast cancer. Using this way, comparing with conventional ultrasound and contrast-enhanced ultrasound, if we can combine them, or we can have our diagnostic efficacy of 0.844, which is highly than the conventional ultrasound and conventional contrast-enhanced ultrasound. So this paper already be published in European Radiology, and these are the groups of our SRUS team in Region Hospital. And the third part is SRUS. We try to use this technology in interstitial lymphatic network of breast cancers, because we know the function of the lymphatic system. It can not only drainage institution fluid and lymph to maintain fluid balance, and also participating in immune response and the surveillance. So the interstitial lymphatic network, which we call ILN, closely correlated with tumor invasion and metastasis, and often occur at the level of the ILN. So we use this way On the ultrasound-guided intratumoral injection, we injected the Sonovil, of course, with diluted, only 1 milliliter Sonovil, and we diluted into 5 milliliter. And the dose should be very tiny, but it determined by the tumor size and the components of the mass. And when we inject it into the tumor, it should be, make sure that the aspiration should be blood-free. Because if there's contrast agents that enter into the blood circulation, this might disturb your results of analysis. Using this way, let's see. SRUS characteristic of the institutional lymphatic network in breast cancer. It should be lower density, lower proportion of duct-like structure, and lower velocity, and lower complexity. Because we think that maybe for lymphatic vessels are structurally collapsed or non-functional within malignant breast tumors, and the SRUS sometimes may underestimate the number of lymphatic vessels. But in contrast, the characteristic of lymphatic vessels in normal breast tissue or benign one are still preserved. And the majority of lymphatic vessels within malignant tumor are often destroyed and replaced by newly formed tumor stroma, which can lead to extremely higher institution flow pressure in the tumor. So this may result in the lower flow velocity observed in the institutional lymphatic network in breast cancer. Just like these are two cases, in the benign breast tumors, the fine institutional lymphatic network structure is evenly distributed peripherally and centrally, but the ductal branching is visible, with large ductal structures on the peripheral branching into smaller structures towards the center of the tumor. While in the malignant one, the ILN structure is more disordered and unevenly distributed, with duct-like structures mainly located at the periphery of the lesion. So we can also see the branching of the ILN is not distinct. So these are two cases. One is fibroadenoma, and another one is the intraductal papilloma. And the fourth part is SRUS that we try to use in Hashimoto's thyroiditis via the non-Hashimoto's thyroiditis. And we also use diluted contrast agents using this way 1 millimeter into 5 millimeter flows, and only use 1 milliliter dose of contrast agents and inject it into the thyroid gland directly. And we can see the Sonovil flows from the institution spaces into the lymphatic system. And in this way, we can follow the contrast agents from the thyroid parenchyma into the lymphatic vessels, and then showing the lymph nodes. We have these maps, just like what other professors have already shown us. And first, we just compare the URM parameters with comparing in the Hashimoto's thyroiditis and non-Hashimoto's thyroiditis groups. We can see some preliminary results of parameters. There's some of distinct significance of statistical results. And then we try to see the SRUS in the ILN in thyroid lymphatics. We can show this. Following the contrast agents, we can also show the lymphatic tract and also the lymph nodes finally in the lateral cervical parts. So we think because the pathological changes in Hashimoto's thyroiditis, the thyroid follicular atrophy and institution fibrosis and the granular structure remodeling. So the lymphatic infiltration and inflammatory compression or obstruction of the microlymphatics within the thyroid gland leads an imbalance in the dynamic of the thyrolymphatic network. So the Hashimoto's thyroiditis disturbs the normal structure of the lymphatic network, thereby affecting its drainage function. And the last part is in lymphoma. Because in our institutions, currently, as we all know, the current imaging techniques for evaluating lymphoma, including CT, PET-CT, also B-mode and color Doppler. These methods are limited to assessing microscopy morphology features of a lymphoma, such as we can only use size, blood supply, and hilum structure. But for contrast-enhanced ultrasound, has higher sensitivity and specificity for detecting necrosis, sometimes within the lymphoma. And it's valuable for guiding biopsy. And in our hospital, we have nearly 2,000 cases of lymphoma biopsy in our hospital. First, we compared the SRUS with the conventional intravenous one, microvascular in lymphoma, and try to compare if there is any useful diagnostic method to differentiate diagnosis, such as for the proliferation of lymphoma. So we compare Ki-67, high expression group, and the lower expression group, and we have some great news that we can differentiate these two groups. And Ki-67 high expression NHL, it have large vessel distance and thinner vessel diameter. And we also use two-way dual vessel SURS imaging in lymph node. And this time we injected our upstream lymph node by this way. And actually, we should show this target lymph node, the microlymphatic circulation in this lymph node. So by this way, we can show this is artery. There's no contrast enhanced in these parts, but this is for intravenous way. So using this technology, we can have both microvessel imaging and microlymphatic sinus imaging. And then why we do this? Because we all know for NHL, just like B cell, diffuse large B cell lymphoma and T cell oriented NHL, actually they are totally similar in conventional ultrasound. And so in this conventional ultrasound does not perform well area, how can we use SRUS to do something new? Yeah. So we do these studies, and we use dual vessel SURS imaging in differentiating the subtype of a B cell and a T cell lymphoma. And we found there's a lot of useful, valuable parameters that can have statistical analysis differences. So just like this is a two case. One is this is a B cell follicular lymphoma. This is an intralymphatic way. This is an intravenous way. And this is a T cell lymphoma patient. The same lymph nodes. This is a bilymphatic way. This is by intravenous way. And with our 49 cases of dual vessel SURS series, we use Larson regression to select the valuable features from the abundant parameters and training a model to predict the subtype NHL and the validation of model performance. So to the best balance between model complexity and prediction accuracy when we get our area on the curve of 0.831. So the next part is the consensus of statements of SRUS. As we all know, since we have a lot of beautiful images and abundant parameters, how can we analyze them and how can we use them? Because we all know the quantitative parameters studies actually is very hard to do because every group of sample are different. You may have different results of different study, like maybe in this institution or in other institutions, you might have different cut-off value. You might have different valuable features after you analyze them. So we think we need artificial intelligence to help us, because from the imaging acquisition, from the ROI segmentation and feature extractions, and ultrasound microvasculomics should be the future of SRUS analysis. So our group, my leader is Dr. Zhou Jianqiao from Beijing Hospital. We already write this paper and published it in European Radiologists. We think this is a bright future of SRUS, and also because the tumor have heterogeneity, so SRUS-based habitat imaging might be another aspect that we can do further studies. So we think the most beautiful scenery is still ahead. So thank you.
Thank you, Professor Gordon. I think the future is very bright, and what you showed was very, very impressive.